Spinning Baby's perspective on labor is looking at how the mom and baby work together in this labor process. Labor is a continuum from the ripening of pregnancy all the way through the beginning of labor, spontaneous onset of labor. It just grows and it ripens and develops. Whether or not you're intending to have a totally natural birth with no medication, a totally physiological, spontaneous onset of labor, or whether you're expecting to have some help from an obstetrician or midwife with pain management, maybe with a labor induction, the more that we can support your hormones to function spontaneously as much as they are able to within the situation that you're in, the better it is for you and the baby. We want to support labor as nature intended. Even though you're getting a lot of information about labor progress, balance, and moving the baby through your pelvis, we don't want to emphasize this as if you have directions to follow during your labor. We want to support your instinctive movements, that spontaneous onset of labor, and the spontaneous physiological labor progress. And to support labor as nature intended, we need some things to support the hormones of birth. We need some privacy, some quiet, and a dimly lit room. When we're talking about labor, the first thing we need to do is have the baby engage into the pelvis. The baby has to get into the pelvis before the baby can get through the pelvis. Before 38 weeks, we have a baby that's floating above the brim of the pelvis. And so now we have the head starting to dip in, but the baby is still ballotable, which means if the nurse, midwife, or doctor were doing an exam of the baby's head inside the mother, they would be able to wiggle the baby's head. Or through the abdomen, they would be able to move the baby's head. That's ballotable. The baby's parietal eminence in the back comes around the sacral promontory. This big bulge is something that the baby has to navigate around. And remember that the baby is in the hammock of the front, so that parietal bone comes around the sacral promontory. The baby comes into the pelvis. As the baby's head drops further into the pelvis, we have engagement. 4/5 of the head are into the pelvic brim, and that's engagement. Sometimes people will call this lightening or dropping because suddenly the mother feels lighter, she can breathe deeper, and dropping because the baby comes lower. If we have a baby that's not engaged at 38 weeks, then we want to get more balance and attend to the reasons why the baby might not be engaged. Almost 50%, 47 to 49% of those first-time mothers who start labor without the baby engaged in the pelvis end up with a cesarean section. Engagement is important for spontaneous onset of labor. It usually happens first, but labor can start before engagement too. Let's talk a little bit about the difference between the anterior baby engaging and the posterior baby, and what the posterior baby may or may not do for engagement. Now this is a pelvis that's lined up with my spine, and here's my baby curled up in my abdomen. The crown of the head is coming, and the parietal eminence is dipping in. And you see how the baby is tube-shaped and can fit into the pelvis when the baby is flexed, coming into engagement. There we have engagement. Let's talk about the posterior baby. Now, the posterior baby is not only facing the front, but very often this chin comes up. The back is extended because it's along the mother's back, and this makes the baby's head longer, and it tends to rest on the pubic bone. So the posterior baby sometimes is overlapping here. So we'll ask a mother to lay down and bend her knees, put her fingers on her pubic bone, and feel if there is like a ledge or something firm in her abdomen. And if she feels that, that's not her. She knows it's not her. She wonders what it is. Well, if it's not her, it's got to be the baby, right? If you get right on top of your pubic bone and just slide your hands kind of firmly into the abdomen a little ways, sort of like.
It's very hard.
You find something hard, or it's hard to do?
Both.
Ah.
It's hard to do, and it's hard.
There's something there. Is there a gap between your bone and the head?
No.
And so now is one further out towards the ceiling than the other?
It's hard to feel. It's like,
They're flush on?
or even back, like that.
This one's further back?
Yeah.
Okay, so she's coming around
Yes.
the top of the bone, finding the head in there. She's finding the head closer to her spine than the pubic bone. What we don't want is the overlapping. When the head is overlapping on the shelf, the baby can't be engaged, right? Because the forehead's not engaged. Even if the midwife, nurse, doctor does a vaginal exam and finds the dome of the head snugly and not ballotable in the pelvis, and they say your baby's engaged, oh yeah, the head is right here. We have to also check the front, because a posterior baby will put the dome of its head snugly down into the pelvis occasionally, not always, but occasionally, while the forehead is overlapping and that baby's not engaged. It's less usual for the posterior baby to engage in my observations. What I see is they rest here, and then sometimes contractions start in a series, and they'll get a lot of contractions that don't bring dilation. The baby might be trying to turn, and the mother will feel grinding on her pubic bone from the forehead moving. It's telling me that the baby is trying to change position. It can start contractions for 6 hours, 12 hours. The mother might go to the hospital and they say, oh, no, you're still at 2 centimeters, which is a normal amount of ripening and pregnancy. And the mother's kind of confused and thinks, is my starter broken? Why won't my baby engaged? Meanwhile, she's feeling these little hands on both sides of her center line, and she's maybe knows or doesn't know that the baby's posterior, and maybe her provider's telling her, or maybe not. Maybe nobody's paying attention because they don't really understand the importance of balance in helping the baby change position. When the baby is able to turn, maybe this mother ripens into balance without doing anything special, or maybe she does some special exercises to get that balance. The baby will move, the contractions will stop, then she'll rest, and when the next time she gets contractions, she'll go through the normal labor cardinal movements of the baby, flexing, descending, rotating, descending more, flexing more, rotating more through the pelvis. Every labor has similar features. There are 6 ways to labor progress that we learned from Penny Simkin. She shares about the cervix, thinking about how the cervix moves. It moves forward before or during labor, and then the cervix starts to thin and get very thin. And the first time mother gets paper thin, then it starts to soften as it thins. So it moves forward, softens, and thins. Those are 3 ways of labor progress before there's any cervical dilation happening. Then we have the baby rotating. The baby is facing the right hip. The baby rotates to face the back. That's part of labor progress, even if it doesn't involve labor dilation. Then the baby starts to descend more, and this will apply the crown of the baby's head onto the cervix and encourage labor progress. We have a full moon coming, so we have some women that are going to be starting labor. Molly Green's labor has started. She's called her loved ones, her doula, her midwife, her doctor. She's feeling her contractions getting longer and stronger and closer together. Mild and enjoyable at first. Pretty soon she starts to get serious. Sometimes these contractions come on pretty strong and suddenly are stronger, but then they continue at that strength, and she learns to cope with them. They go this way, getting longer and stronger until they are one on top of each other like big waves at the beach. And then they move that cervix open. She's dilating. At 4 centimeters, contractions are longer than a minute. They are 3 to 5 minutes apart for an hour or more, usually 3 minutes apart. At 5 centimeters, she often feels that this was more than she bargained for. If she's been in her frontal lobe, in her logical mind, she has to give that up now because she needs to get into the deeper instinctual part of her brain that knows how to labor. That's why we want to support her privacy, quiet, keep the lights dim. We don't want to ask questions. We don't want to give direction. Here we have about 5 centimeters, right? And this is when the baby starts to rotate on the pelvic floor. The mother needs to go from logical brain to instinctual brain, and she needs some support about this time. If she was planning a natural birth, she needs to not think and go into labor land. Her support people need to know this. Her birth partner needs to know that she's going to get very hazy and foggy and no longer talk in complete sentences so that her body can take off. And we need to support that mystery of birth, and not always know how the mother's feeling or what she's thinking, but follow her by her muscle tone. Is she soft in her body, or is she holding her tension? We need to know by her respirations. Is she soft and flowing and breathing well, or is it tight? And then we certainly shouldn't let her suffer or get frightened, but talk to her about that. But if she copes well with 5 centimeters, she goes into that labor land because the endorphins release from the brain. She gets that natural high, just like the runner who hit a wall in their attitude, but they keep running because they know they'll get that runner's high, and then they'll get the endorphins and feel better about it. Well, in labor, the high is yet to come, but the endorphins are there, taking the edge off the contractions. She dilates more to 6, and that's usually a very quiet time in her labor. And 7 is on the verge of transition. It starts to get intense again.
Oh, Emmy.
At 8 centimeters, there's just a little bit of cervix left, just a ring of cervix, but there's so much emotion. It's as if for 9 months you haven't had your period. All those emotions of those missed periods are in that cervix, and as it opens, they're released. So you have different feelings at different centimeters of dilation, and 8 centimeters is a time when the body is saying, get up, get vertical, get ready to catch your baby, get ready to greet your baby. And so that adrenaline is also associated with fear or fear of dying. And indeed, the maiden is on her way out and the mother is being born too. So there's great transformation happening now. At 9 centimeters, it's very intense physically as this cervix is almost around the baby's head. Think about it softening, ripples on a pond, with a flower opening. Finding a visualization, a breath, a rhythm really does help through labor. When the baby is 9.5 centimeters, almost 10 centimeters, there's a lot of molding going on and more flexion. And the baby comes down through the pelvis. When the cervix is all the way out of the way, there is a release of a lot of emotional tension and a resting phase. It's often called the rest and be thankful phase. Fully dilated, the uterus now needs to catch up. The fundus is loose, it catches up with the baby, pushes the baby further down, and the baby enters into the birth canal. Contractions start to get strong once again and move the baby out. We will see a bit of the head slowly appearing, but the perineum needs to thin before it opens around the baby's head. So just as the cervix had to thin first, the perineum needs to thin and becomes thin as paper, and then it dilates around the baby's head. And the baby's head will appear for a while without any change in the perineal dilation, and it seems like the baby isn't coming. But if you notice the thickness of the perineum, it's getting thinner and thinner, And then once it's thin, it sweeps around the baby's parietal bones. The baby comes out. The back straightens and the head starts to extend as it comes through the perineum. When the baby's face is entirely born, now the chest of the baby has to rotate in that buttonhole of the pelvic floor. And from the outside, we actually see the baby start to turn, called restitution.
She's got her stomach. Okay, there's the head, Sally. Beautiful. Sally.
Oh my God.
You got it.
We see in Molly Green the natural process of labor, the natural progress of a physiological labor. Spinning Babies has a perspective of what happens if this beautiful plan doesn't work. You know, this beautiful design is set up to work, but what if there's something unusual happening in the progress of labor? Any problems in labor with sharp pain with the contractions or a slow labor? Back pain. It hurts more than the amount of dilation should, whatever that means. But for instance, it seems like the mother's in very advanced labor and the nurse checks and she's 2 centimeters dilated. It's really important to think of the pelvis as 3 levels: the inlet, the mid-pelvis, and the outlet, and not simply a passageway. That's too vague. We need to think about the brim, the mid-pelvis, which is the narrow part of the pelvis, and the outlet between the tailbone and the tuberosities and the pubic arch at the bottom of the pelvis. This diamond is our outlet. In our fast-paced modern obstetrical world, a mother could hear that her baby doesn't fit. Her pelvis is too small. It's taking too long. What about Susan Brown? We see this burst of activity early in the labor. She thinks, oh, my labor's going great. It's picking up fast. Her providers think, boy, this is interesting. This labor's going fast. But after a couple of hours, and in these hours, she might feel pushy, she might feel nauseous, she might feel shaky, and it seems like she's entering transition already. But then we notice that the contractions slow down, and they're not regular. She doesn't know when to expect them. They come and they go. This is often associated with the baby that's trying to engage. In fact, we're talking about the inlet with this burst of activity. I call it a push-off of labor. Then the uterus says, hey, this baby isn't in the pelvis yet. I'm going to take a break. Contractions are irregular. The hormones build up again. And we have a strong night of contractions. They look like they are progressing well. Everybody's expecting good things. But, you know, that dilation really isn't happening. So if she entered this night of contractions with a 2-centimeter cervix, she might end that night of contractions with a 2-centimeter cervix. What's going on? This is about the baby trying to get in the inlet. We need strong contractions to help the baby. There's something that's not simple or balanced about that situation, whether it's the position of the baby's head or whether it's the alignment of the pelvis itself. Maybe it's a little kittywampus. And the two are trying to work together. So the first job of contractions is to get the baby into the pelvis. Sometimes the posterior baby does engage in the posterior direction, and this might be more common if the baby's on the left side posterior, because the left posterior baby is more likely to be flexed. Remember we talked about right obliquity? Well, that means left curve, right? Remember that? The flexion helps it to fit the pelvis. So on the left, there's a better chance. Directly, then the chin is usually more up. Remember that? And so now we have a bigger head to come through, and that can slow labor down. And sometimes the head doesn't want to fit. That can be true from the right, too. So then we have some challenges, and we might need to do something unique and creative to help the baby reposition and either flex the head and fit or absolutely rotate around and come out. Remember that 65% of posterior babies rotate on their own. Sometimes it's just taking a little longer and stronger contractions. Sometimes it's with movement. And that leaves us with 35% that need some amount of help. Whether that help is a little bit more time, a little bit more movement, maybe some medication to strengthen the contractions, medication to soften the pelvic floor. We think the epidural does some softening of the pelvic floor, or even up to vacuum forceps or cesarean section. So if we can help the baby rotate sooner than later, we start to eliminate some of those risks. So we have a couple of techniques that can help this little egg get into the cup. One is to get that pelvis moving. We can start by sitting on a birth ball, put your feet apart, and then start doing circles on the ball. And we start making those circles with our pelvis, and it helps our little egg drop into the cup. This loosens up the muscles. Let's go the other way. We don't know which way this baby wants to go. And get that little egg in. This is very useful if the water breaks and the baby hasn't come. We want to do balance first and try to get everything open so the baby can rotate. But sometimes you're under pressure to have your baby sooner than later. For instance, when the water breaks and you're working with a provider that's watching the clock to keep an infection away. So then doing circles really helps bring the head down into the cervix. The contact of the crown of the head with the cervix stimulates the contractions. So this is very useful. A great technique to help the baby into the brim when there's regular contractions happening is the abdominal lift and tuck. Now you need contractions that are 3 to 5 minutes apart, but that are happening regularly so you can anticipate when they're about to happen. When you feel that a contraction is about to come, you simply lift the belly up, bring the belly to your spine. Your knees are bent, and your back is straight. You can rock through the labor. When the contraction is done, put your belly back down, shake it out. Take a nice cleansing breath and move the lactic acid out of your muscles with your breath. That's the abdominal lift and tuck, and this is how it works. If the baby is either large or posterior, as this baby is, sometimes the baby gets stuck on the back of the top of the sacrum, called the sacral promontory. And sometimes that forehead is on the pubic bone. So then we flatten the lower back, going to make more room between this bone in the back and this bone in the front. Let's see what happens when we do a posterior pelvic tilt. See how that bone comes back? We can do the abdominal lift and tuck by lifting the baby towards the spine. The contraction brings the baby down and tucks the chin. That way the baby can be in the gymnastic pose of flexion to rotate and fit into the pelvis. And labor usually takes off. This is highly successful for many women. We do this abdominal lift and tuck through the contraction, holding it for 10 contractions in a row. If we miss one because we went to get a drink of water or we weren't in place when the contraction started, then we don't count that one, but the next one resumes the count to 10. And this is very successful to bring the baby into the pelvis. Sometimes we need another position to get the baby into the brim, to open that brim wider. And the way to do that is to arch the back. A lot of women do this instinctively. Unfortunately, they're often given the advice to curl up. But when a mother arches, it's a sign she has good oxytocin, and it opens the brim. Through that night of strong contractions, even though the cervix isn't changing, we do see progress because in the morning, we see the baby on the left, flexed, and in the ideal position to start labor. Then the uterus needs to rest. So then we see a recovery phase. Often through a day, we have some contractions happening periodically, 20 minutes, 30 minutes, 1 an hour, 5 an hour, but they don't stay regular and they're not changing the cervix. The mother rests, she eats, she drinks, she goes about her day. If her water isn't broken and the baby's doing well and the mother's doing well, there is no reason to change any plan that she has because now her baby's engaged and over on the left. When the labor starts again, it'll pick up progress. And then typically we go through a labor like any other. It might be drawn out a little bit if the mother is tired, but with support and with some naps and some meals, she's doing fine. Because this is a Spinning Babies class, we can't make it that simple. We have to talk about the next challenge in labor, and that's the 7-centimeter stall. It's a mid-pelvis issue. In the mid-pelvis, we usually see the labor staying at 7 centimeters for 2 hours, 3 hours, 4 hours, sometimes I've heard 12 hours at 7 centimeters. Well, we don't have to wait that long. We know if the labor is strong, we have strong contractions coming like big waves, but there isn't labor progress, that we have to help the baby through the mid-pelvis. Sometimes the baby is facing the hip. The baby was trying to turn, but the lack of space in this pelvis isn't letting the baby turn. I'm going to have you be the sacrum. All you have to do is hang on to where the pelvic floor attaches at the coccyx and the sacrum. She's the back of the mother. You're going to be the symphysis pubis, okay, right? Mm-hmm. Each hand hangs on to the front of the pelvic floor. Okay, now sacrum's higher, symphysis is lower, because as we stand up, our pubic bone is much lower than our sacrum. So now we have the pelvic floor buttonhole. Can you tip your hand like that? And you can see this buttonhole. Okay, we have the baby on the mother's left, facing her right hip, right? Because Amber's the back of the mother. And the baby is settling down into the pelvis. It needs to get around the mother's sacrum, so it tips its head so that this parietal eminence, can you feel the little corner of your head? That comes into the pelvic floor first. And that is really important to help good rotation of the baby. The baby's chin is tucked to his or her chest. The parietal eminence comes into the pelvic floor at about 5 centimeters in the first-time mom. And you get soft. The pelvic floor is guiding the baby. The strong contractions are bringing the baby onto that pelvic floor. The pressure is rotating the baby, and the baby rotates another quarter turn. The baby comes down a little bit more. The cervix would be here, see? opening up to 10 centimeters as the baby comes through the lower part of the pelvis. So this is the role of the pelvic floor, to help the baby to rotate. And when the baby's head is in flexion, the chin is tucked to the chest, then the baby rotates nicely towards the back. Now, what if we had a tight right side? So hang on and pull the right side tight. What happens when that baby comes down is that as the baby comes through, the parietal bone catches that side, but the baby starts to tip. And now we have this parietal bone coming through. This ear is closer to the opening than this ear, right? And we call that asyncliticism. Asyncliticism means the baby's head is tipped, as if the baby is saying, what am I supposed to do? What do you want me to do? I'm just waiting here to have room to come down. So we do the sideline release, and that softens this side. We don't know which side is really necessary. We soften both. And then, even if the baby remains asynclitic, with some work, with some movement and determination, the mother continues her labor with the baby whose head seems to be at a bigger diameter when it's tipped, right? And this is becoming a situation caused by our modern living of driving a lot, crossing our legs a lot. So we're going for balance. And when we need a fast balance, we do the sideline release. Any problems in labor with sharp pain with the contractions, or a slow labor, back pain. It hurts more than the amount of dilation should, whatever that means. But for instance, it seems like the mother's in very advanced labor, and the nurse checks and she's 2 centimeters dilated. This would be a reason to use the sideline release. And when labor's taking a long time and is strong, or maybe labor's putzing and it's not strong and it doesn't pick up, the sideline release helps many women. It's the first thing that we try for a 7 centimeter stall. Now I'm saying 7 centimeters, but it could be 6 centimeters, it could be 8 centimeters, but classically it's 7 centimeters. We can open up the mid-pelvis with a lunge. The idea is to get these ischial spines further apart. I'm going to put my foot here at the beginning of a contraction and rock my pelvis open. It opens one side of the pelvis, allowing more room for the baby. I keep my knee so that from overextending my toe, and this rocks open the pelvis. And I think that we need to do the sideline release first so that we've softened the muscles, and now we open the bones. We do one contraction, and then we put our foot down. When the next contraction begins, we put our foot up, and this makes a great movement. It helps many babies rotate, it soothes back labor, and it really opens these ischial spines, so the baby facing a hip at the mid-pelvis does not have to be born by a cesarean section, but can rotate in this extra room that we've made through the contractions. So we're going to do 3 on the left, and then we're going to do 3 on the right. We don't know which side the baby needs space on, so we give it an opportunity on both sides. And I think we should use it after the sideline release, but some mothers will use it first, and that's fine too. It's see what progresses the labor. Labor will take off again. Sometimes, if it's not the sideline release, it might be an epidural. Occasionally does that. Occasionally epidural slows everything down, causes too much softening, and the baby to go into a poor position. And sometimes the epidural releases the muscles and lets the birth finish. So it's a toss of the dice, which it's going to be, and it's not exactly 50-50. Having the epidural help labor progress is more towards a 10 to 20%. But it is one of the tools that can be used when it's appropriate. Then labor is taking off. In the case of the sideline release, it's taking off with mother's own powers, getting very strong, going through transition, but occasionally we see a 9 centimeter stall. Not that often, but occasionally. We're waiting for the baby to mold some more, to flex. So if this is taking some time, rolling the mother over to her tummy almost being into the mattress. Remember, we did that this morning with the flashlight going towards the couch. So if she gets in that position with a lot of pillows under her leg, then that helps the baby do what it needs to do to get through this last little bit of cervix. Again, this is not very common, but it's common enough. The solution is flexion and more molding. That lean over positions, very satisfactory and very successful for that. If the mother has an urge to push during this time, she can pant, and that's a little bit tedious. Pa, 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 pa. And if her body can't stop pushing, I learned a tip in a yoga magazine to stick the tongue out and pant. And I'll make the doulas do it with her, and I'll do it with the mother if I have to. And we'll put our chins up and pant. I know it looks silly, but it's really effective. And then as the cervix comes around the head, then there's usually a rest time, a rest and be thankful time. And then contractions bring the baby down lower into active second stage. To get the baby through the outlet, we can squat. Squatting is a wonderful way to open the outlet. And so by squatting, we're coming down, opening the pelvis, making these sits bones wider apart. You can get up between contractions and just squat flat on your feet with the contraction. And then the final part of second stage is crowning. Violet's labor is very similar to Susan Brown's. She has that push-off contractions that look promising, but indeed the next day they slow down. And then a very strong night of contractions, fiercely strong. In fact, notice how strong these contractions are, where she is 3 centimeters dilated, compared to the contractions where she's 8, 9, and 10 centimeters dilated. Why is this? Well, in Violet's situation, she had a narrow front to back diameter. She had what's called a platyploid pelvis. Women aren't all shaped the same. We have different pelvic types. Violet's pelvis was very narrow front to back. Only 5% of women have this. And her babies did start out facing the front and could not get in. So she had a warm-up night and then a very strong night at 3 centimeters where her baby finally did rotate around. But it took so many hours to get into the brim of the pelvis and engage that her uterus needed to rest for a whole day. She had a few contractions, but she was able to eat and drink. And then when her labor started again, it was more like Mrs. Green's labor, but it came slow. And yet she pushed out her baby too. What about Scarlett? Occasionally it's true that a woman's pelvis is too small for her baby. Maybe she had rickets in childhood. Maybe she had an accident or surgery on her pelvis. And there's 2 patterns that we would see. In Scarlett's case, this nice round, large inlet was only the size of 7 centimeters. She went into spontaneous labor, labored, it was discovered. She was helped to finish the birth with a cesarean section. The difference between Violet and Scarlett are that with Violet, her baby needs to rotate, and then the baby fits and can be born. With Scarlett, her baby was in an optimal fetal position and was never able to descend. The first sign of progress is often the baby rotating when there has been a long labor. But if the baby's already rotated in a perfect position, good, strong contractions are happening for at least 4 hours of transition-like contractions. But there's no descent. And the baby's already rotated, so we're not waiting for that. Then we have proof that the baby's not likely to fit. If the baby is descending, even if it's little by little, then we are having progress, and that's not the same. Then if the mom and baby are doing well, and the provider is doing well, we can continue. This has been an introduction to spinning babies for pregnant parents to prepare you for childbirth, and I hope that you use some of these activities together as couples and as friends and with your doula. Make room for your baby so that your baby can get into an optimal fetal position. Labor is a challenge, birth is a challenge, but it's a glorious one. It's going to bring you to your edge and show you you can take another step higher. Whatever your birth journey reveals, whatever happens in your future, your baby loves you and is so happy to be with you. Love yourself too. The most important thing is love.
Stones hurt and